All right, let's dive right in with a scenario you're going to see all the time. A patient comes to you and they're just wiped out, totally exhausted. Now, that could be a lot of things, right? But one of the biggest culprits is anemia. So in this explainer, we're going to break down the most common types you'll face, focusing on exactly what you need to crush it on your PEBC exam.
But look, before we get lost in lab values, let's remember we're talking about people. Anemia isn't just some number, it affects everything. When you see a patient with this cluster of symptoms, I'm talking fatigue, brain fog, feeling short of breath, a pounding heart, your pharmacist's brain should immediately be screaming anemia. These are all signals that the body's tissues are literally starving for oxygen.
So here's how we're going to tackle this. This is our roadmap. We'll start with the basics, then get into the real nitty-gritty of diagnosis and treatment. We'll even hit some special cases and wrap up with some super high-yield pearls for your exam. By the time we're done, you'll have a rock-solid way of thinking about anemia.
Okay, let's build our foundation. We're starting with the core concepts. Because before we can even think about treating anemia, we've got to be crystal clear on what it actually is and what we're trying to accomplish. Everything else we talk about today builds on this.
Here it is, the main idea. Anemia is fundamentally an oxygen delivery problem. I want you to picture your red blood cells as a huge fleet of delivery trucks. Oxygen is the cargo. With anemia, you either don't have enough trucks on the road or the trucks you have aren't fully loaded. Either way, your body's tissues aren't getting the deliveries they need to function. It's that simple. Now, if you're studying for the PEBC, you need to tattoo these numbers on your brain. Seriously, these are the official WHO diagnostic cutoffs. Think of them as the magic numbers. The second your patient's hemoglobin dips below these levels, bam, you've officially got a diagnosis of anemia. You have to know these cold.
And you know, when we treat anemia, we're not just chasing lab values. Our real goal, our main goal, is to make our patients feel human again. We want to give them their energy back, clear up that brain fog, and let them actually enjoy their lives. Fixing the number is just how we get there. Improving their quality of life, that's the real prize.
Okay, so we know what anemia is and what we're aiming for. Now, how do we figure out what's going on? Well, we turn to our single most powerful diagnostic weapon, the complete blood count, the CBC. This one simple test is the key that unlocks the whole mystery.
So let me be super clear. It doesn't matter if your patient is young, old, male, female. If they present with that classic fatigue, the very first thing you do is get a CBC. It's the absolute starting point for your investigation. The results will literally tell you which path to take next.
And this right here, this is your secret weapon. This algorithm is your roadmap for diagnosing anemia. It's going to guide you step by step. We are going to keep coming back to this flowchart, so take a good look. Get comfortable with it. It's going to be your best friend.
Now, if the CBC is the key, then the MCV is the very first clue you look for. All it does is tell you the average size of your patient's red blood cells. Just think, are the cells too small, too big, or just right? Answering that one simple question is what gets the whole diagnostic ball rolling. And here we go. This is the first major fork in the road on our diagnostic journey. Is that MCV low, normal, or high? This one number instantly puts the anemia into one of three buckets: microcytic, normocytic, or macrocytic. And from this one branch point, we can start to really narrow down what's going on.
All right, let's head down that first path. We're talking microcytic anemias, where the red blood cells are too small. And we're going to kick things off with a classic clinical showdown: iron deficiency anemia, or IDA, versus anemia of chronic disease, or ACD. This is a super common puzzle, but once you know the clues, it's easy to solve.
So you get the CBC back. The MCV is low. Now what? Is your patient truly low on iron, or is there something else at play, like a hidden chronic inflammatory disease? This is a textbook PBC scenario, so let's play detective and look at the lab clues that are going to help us crack this case wide open.
To solve this mystery, you have to understand one crucial character, a hormone called hepcidin. Think of hepcidin as the bouncer at the nightclub of your body's iron stores. In true iron deficiency, hepcidin levels are super low. The bouncer's gone, the doors are wide open, and your gut is absorbing every bit of iron it can find. But in anemia of chronic disease, inflammation tells the body to crank out tons of hepcidin. The bouncer is back, and he locks all the iron away in storage. The iron is there, but the body can't get to it to make red blood cells.
This table right here, this is your cheat sheet for telling them apart. Let's walk through it. First, look at ferritin. Ferritin tells you how much iron is in storage. If it's low, you're almost certainly dealing with IDA. But if it's normal or even high and there's inflammation, think ACD.
Next, check the TIBC. That's a measure of transferrin, the protein that transports iron. In IDA, the body is desperate, so it makes more transport proteins, so TIBC is high. In ACD, it's low or normal. See the pattern?
Okay, so you've put the pieces together, and you've diagnosed your patient with iron deficiency anemia. Fantastic. Now comes the fun part, the part where you as a pharmacist get to be the hero. Let's talk about how we're going to get their iron stores back up and get them feeling great again.
Now, before we even touch a single pill, let's talk about the plate. Counseling on diet is a huge part of your job. A simple tip to teach your patients is meat and see. Meat is a great source of heme iron, which is super easy for the body to absorb. And taking some vitamin C with meals. That helps the body soak up the non-heme iron you find in plants. And just as important, tell them to skip the tea and coffee right around meal times, because they can totally block iron absorption.
And this slide, this is a non-negotiable must-know for the PEBC exam. You have to know the different oral iron salts, but what's really critical is knowing how much elemental iron is in each one. See, if you want to give a patient about 100 milligrams of elemental iron, you'd need 1 tablet of ferrous fumarate, but almost 2 of ferrous sulfate, and almost 3 of ferrous gluconate. Getting the dose right depends on knowing this.
Okay, here's a clinical pearl that's a total game changer. We used to think we should blast patients with iron 3 times a day, but what we know now is that the first dose of iron spikes hepcidin, remember our bouncer, and that blocks the absorption of the next dose. It's completely counterintuitive. So by giving 1 dose every other day, we let hepcidin fall back down and we actually get more total iron absorbed. Plus, it's way easier on their stomach. It's a huge win.
So how do you know if your treatment is working? You look for 2 key signs. First, within about a week, you want to see a big jump in their reticulocyte count. Reticulocytes are just baby red blood cells. A high count means the factory in the bone marrow is back in business. Then, a little later, you should see the hemoglobin itself start to climb steadily. If you don't see this happening, you got to go back to being a detective and figure out why.
So when do you have to pull out the big guns and switch from oral tablets to IV iron? Well, for most people, oral iron works just fine. It's cheap, easy, and effective. But if your patient can't absorb it because of something like celiac disease, or if the GI side effects are just too much, or if you need to get their hemoglobin up really fast, that's when you start thinking about parenteral iron.
All right, we have totally conquered the small cell microcytic anemias. Now let's switch gears and head down a different path on our algorithm to the big cell macrocytic anemias. Specifically, we're going to zero in on the megaloblastic anemias, which are caused by a lack of 2 key vitamins, B12 and folate.
If you only remember one thing from this whole section, let it be this. Vitamin B12 deficiency can cause severe and sometimes permanent neurologic damage. I'm talking numbness and tingling, serious weakness, even dementia-like symptoms. This is what makes B12 deficiency so much scarier than just a folate deficiency, and it's why we have to be so careful.
And that brings us to a critical life or death safety warning, so please listen closely. You should never, ever treat a patient with macrocytic anemia with just high-dose folic acid until you have ruled out a B12 deficiency. If you do, sure, you might make their blood count look a little better, but you'll just be hiding the real problem, allowing that devastating nerve damage to get worse and worse in the background. It's a classic clinical trap you cannot fall into.
So what's the treatment? Well, for folate deficiency, it's easy, just oral folic acid. For B12, we've got options. We can give injections or we can give high-dose oral B12. And here's the great news. For most patients, taking a high-dose pill every day works just as well as getting shots. This has been a complete game changer for our patients.
Here's another tip that could literally save a life. When you start treating someone with severe B12 deficiency, their bone marrow wakes up and goes into overdrive, churning out millions of new red blood cells. But to build all those new cells, it needs a ton of potassium, which it yanks right out of the bloodstream. This can cause a sudden, dangerous, and potentially fatal drop in potassium levels. You have to monitor their potassium like a hawk for the first few days of treatment.
Okay, let's bring it home with a lightning round of high-yield tips and special situations. This is the stuff that you absolutely, positively have to know, both for the PEBC exam and for your day-to-day practice.
Pregnancy is a super high-risk time for anemia. A growing baby needs a ton of iron and folate, and it pulls it all from the mother, so her stores can get drained fast. That's why we're so aggressive about screening and supplementing. And hey, that alternate day iron dosing we talked about, it's a fantastic strategy to use here to help with tolerance. And of course, folic acid supplementation is absolutely non-negotiable to prevent those awful neural tube defects.
And if you have a new mom who is breastfeeding, you can and should tell her with confidence that it is perfectly safe to keep taking her iron and folate. In fact, it's essential. Not only will it help her rebuild her own stores after pregnancy, but it also makes sure the baby is getting what it needs through the breast milk. It's truly a win-win.
Okay, here are your final rapid-fire exam pearls. Burn these into your memory. Number 1, a man or a postmenopausal woman with new iron deficiency, it is a GI bleed until proven otherwise. Go look for it. 2, a normal MCV, don't be fooled. It could be a mixed picture of both iron and B12 deficiency. 3, enteric-coated iron, just don't do it. The absorption is terrible. 4, anemia of chronic disease, it's all about that troublemaker, hepcidin.
So let's end with one last case to put it all together. You've got a 65-year-old guy, he's taken an NSAID, and he shows up with microcytic anemia. What's your next move? Now, if you said start him on iron, you're only half right. The single most important, most critical thing you can do for this patient is to figure out why he's losing iron. In his case, it's almost definitely a GI bleed from the NSAID. And that's the final message I want to leave you with. Don't just treat the anemia, find the cause. That's how you'll go from being a good pharmacist to a great one.